Welcome back to all of you that are watching, and welcome back to those of you that are joining us here in Gamle Festsal at the University of Oslo. We are delighted that you have chosen to spend your day with us, learning more about One Health. And we will now move directly to the third session. And to lead us skillfully through that session, we have Executive Director Ågot Aakra in the Division for Environmental Health and Climate. It is new. It's a new division, and she's a new head. She was the former dean at the Norwegian University of Life Sciences. So this is a first time for you in your new capacity leading this. And welcome, Dr. Aakra, the floor is yours.
Thank you, Jeanette. Great to be here. And I have the pleasure of chairing this session, One Health, Governance and Society. The schedule is strict. We have 4 speakers, and they have 10 minutes both, or all of them. And I will keep the schedule and announce you when the time is up. There will be questions by the end of the session, so just save your questions to the last 20 minutes. For the speakers, I ask you all to stand here by the mic. The picture on the wall there is also copied here, so it's easy for you to follow the presentations. And after the presentations, the speakers are invited to sit here to answer the questions from the audience. So, the first speaker of this session is Dr. Zuzana Nordeng. She is a senior advisor at the Norwegian Institute of Public Health. Zuzana is the NIPH's project coordinator for the One Health EGP. She is a health economist and sociologist by training, and her research interests are health systems, EU patients' rights policies, as well as One Health implementation and climate. She has a European Master in Health Economics and Management from the University of Oslo and University of Bologna. Her PhD thesis is on EU public finances management systems. So, Zuzana, please.
Thank you very much. I have to apologize for smuggling in a little bit of water. I lost my voice yesterday, so if I lose it again, I'll need a little bit of water. And now I can go to the next slide. This presentation is mostly presenting research both, but also implementation of One Health structure in Europe. This is an activity that is under the project called Cohesive, and the Cohesive is a project under the umbrella of One Health European Joint Program. The Cohesive project is led by the Dutch Institute of Public Health, and normally it's the head of epidemiological department who is presenting this topic, although as already many people mentioned, it's relatively difficult to move around between the countries in these days. So I got delegated by Kitty and my colleague, project leader Jørn, to present this activity under the project Cohesive, and it's on the building One Health structure in Europe. And how do we do it? Again, we could have several, let's say, opinions how to build One Health structure in Europe, although from the, let's say, zoonotic expert, it's mostly related to the surveillance, signaling, assessing, responding, and controlling zoonoses at the national and regional level, but also within and between EU countries. So how do we did it? We did it, as it's defined on the slide, that we tried to develop a guideline to support this country, and we tried to not to go into many details and not to specify separate hazards, because each country has also different procedures how to deal with risk analysis of zoonoses. So we try to give some guidelines that can be applicable and further develop within the countries on the national and the regional level. This is a presentation that should be maybe presented in 30 minutes, so I'll speed up now. And this is a slide from the website that is built presenting the guideline of One Health, and you see several topics that are presented. So what is the goal, focus, how do we do things, and who is relevant? So normally it's the One Health professionals in zoonoses. So specifically it's veterinarians, the medical doctors, the food safety specialists, but also we mentioned the experts on the climate and also the social scientists. I will run through. This is a slide, what is the risk analysis? I think most of the people are experts on this, so I will just run through this. And I will show you a slide that is consisting of the 6 activities that built the One Health risk analysis system, and it is One Health signaling, One Health risk assessment, One Health feasibility assessment, One Health risk management, One Health risk communication, and One Health governance. And in addition to that, we are defining also terms of reference, what these guidelines draw, tools that could be used in this activity, as well as another aspects, and that are, for example, I will go to the slide that is describing the barriers, because as a One Health specialist, especially when you are doing, let's say, outbreak investigation, you are facing some barriers, and these barriers that have been identified, there are many barriers, but the most prominent were the political will, trust, sharing information, and communication. These have been selected based on the interviews and the workshops that have been carried out through the life circle of the project that started in 2018, and it's in the final phase. And it's still there is a lot to be developed. So we are trying to push through the task to another project that is ongoing called Matrix. This is the slide, the last slide, that is showing the partners of the project. As you can see, it's quite a European project, and from Norway, it is a Veterinary Institute that is involved in this project, heading by Malin Jonsson and Cecilia Wolff. And from Public Health Institute, we are involved in many work packages, and there are many people involved in cohesive, but I will say that the project leader is Solveig Jure. And the last word is, as you already heard many times in relation to Corona pandemic, that you cannot predict the future, you cannot predict when the next pandemic comes, but you can prepare for it. So I hope that these guidelines can also help to prevent the future pandemic or future outbreaks. Thank you. I will give word to the next speaker, who is going to talk a little bit more about system mappings. That is one element of these guidelines. Am I in the time? Yeah?
Thank you, Zuzana. The next speaker is Cecilia Wolff from the Norwegian Veterinary Institute. Cecilia, you are a veterinarian and a senior researcher in the section for epidemiology at the Norwegian Veterinary Institute, and you work mainly with projects and tasks on infectious disease surveillance, outbreak investigation, and risk assessment. And the title of your talk is A Systems Approach to Understand the One Health Risk Analysis System for Zoonoses in Norway. Please.
Thank you, Ågot. Good afternoon. Thank you for allowing me to present our abstract at this conference. There. Zuzana just gave you an introduction to our to the Cohesive project. It's one of the integrative One Health EGP projects. So it's not a research project, but an integrative project. And one task within Cohesive is to develop these guidelines that Zuzana mentioned to support countries who wants to strengthen their One Health risk analysis systems for zoonosis. And specifically focusing on the signaling, the risk assessment, and the response and control of zoonosis. So this is a screenshot from the website where we will put these guidelines. And the work that I present today is focusing on the system mapping of the current situation, that chapter of the guidelines. And in the guidelines, we write that we have found out during the work with Cohesive that the best way to do this, the system mapping, would be to arrange a workshop to draft the current system and to learn what is already in place that you can then build upon when you want to start to strengthening and changing in your system. And if you could identify any gaps in collaborations, and also very importantly, to get to know each other, to build relations, trust, and gain support for the strengthening work that you will carry out. Our objectives were to test a systems approach for how to do this workshop. And another objective that we had was to bring together some central actors from the Norwegian One Health risk analysis system for zoonosis. And the way we did this was that we adapted a systems approach for evaluation of One Health initiatives. And this framework was developed by the Cost Action NEO, the Network for Evaluation of One Health, that Barbara Hessler, that you heard before lunch, was a key person in. So this framework is for evaluation of initiatives. We wanted to map a current system. We started by putting together a team of change agents at the Vet Institute and the Public Health Institute. And that was us in the project who work at operational level in the One Health system for zoonosis. So we identified stakeholders in the Norwegian system, and we started drafting a number of initial system maps, indicating the resource systems, the resource units, governing units, other components of the system, and how all these components in the system connect with feedback loops and causal loops, etc. We did several of these maps, and then we discussed them with a few colleagues at the Vet Institute and the Public Health Institute. So we were still quite a small group of people that were involved. When the pandemic, when the COVID restrictions allowed, after quite a while, we arranged a workshop with some key stakeholders from the system. So they were from the Public Health, Vet Institute, and the Food Safety Authority. This was a 1.5-day workshop where we had a blend of systems theory lectures, exercises individually and in small groups, and then step by step we put together one large map of the Norwegian One Health risk analysis system for zoonosis. And we gave the participants 4 example zoonoses to work with during these exercises. And then as we went along, we had evaluation and feedback from the participants. And yeah. So these are 2 photos from the last session in the workshop, just to illustrate how we worked. This is bringing together all the different smaller maps and parcel maps that we had worked with during the workshop. And all the green post-it notes are different stakeholders or other components of the One Health system. And on the right picture, you can see the red and blue arrows. They indicate signaling and response and control measures, how that information is forwarded in the system. So what did we learn from this workshop? We did produce one system map. This map was both less and more detailed than our initial maps produced by the little project group. The larger group of participants in the workshop identified some stakeholders that we had not thought of and links and connections that we had not thought of in our small group. We in the project group, we had more time, so we had closed more feedback loops and causal loops than the workshop managed in quite a short time. So the map that the workshop produced was not finished. It was not perfect. However, these system maps will never be finished, and they will always differ a bit depending on who who is participating in creating them. And I should also mention that system thinking and system theory is not a new thing, but however the application in One Health is new, and then the NEO project, they have been in the front of that work, getting system thinking into One Health. So back to the map. Even if the map is not perfect or final or complete, maybe the discussion and conversation around it when you are building the map and talking about this is perhaps even more interesting when participants from one stakeholder share their experiences and their perspectives on the system with someone from another stakeholder. And we agreed that this workshop with this system thinking and systems approach, it was a useful way to start a conversation on the One Health risk analysis system for zoonoses in Norway, and it was a useful way to engage people. And then back to these 4 example diseases. Interestingly, almost all groups chose to work with a foodborne zoonosis. And we agreed that that is probably because foodborne zoonoses are routine, it's something that almost everyone has experience with. Rabies was another example disease that no group chose to work with unless we told them to do it. And because that's a zoonosis that in Norway we don't have that much hands-on experience from. There were some limitations we found to this, our approach with this workshop. We only had a limited number of stakeholders, 3 present, and we only had about 20 participants. We had wanted a much larger workshop with many more stakeholders, but due to COVID restrictions, we couldn't do that. We had no one from academia present. There were a number of other government agencies that were not there. The food industry, farming organizations, the ministries, and so on. We didn't have any local public health authorities, the municipality medical doctors present, and they are really a key stakeholder in this zoonosis system. But none of them had time to participate because they were just too busy. A second limitation is that this was a lot to cover in 1.5 days. For most of the participants, this was the first experience with system thinking. And you can look at it as a primer if you want to have, a more final and detailed map is important, you could do, this was a primer into system thinking, and you can do interviews or some questionnaire or maybe a second round of a workshop to get that more detail. Thank you, that was
Thanks to you, Cecilia. We will now switch to the prion diseases. The next speaker is Jørn Våge. He's a senior researcher at the Norwegian Veterinary Institute, the Wildlife Health and Chronic Waste Disease coordinator at the Institute. The title of Jørn's talk is Chronic Wasting Disease Establishing in Europe with Profound Effects on Human Culture? There you go. Please.
Thank you. Next is green, I guess, yeah. Thank you for the introduction. I'll talk a little bit about chronic wasting disease as an example of a disease that is quite political and difficult to manage. It's a prion disease, as mentioned. It's a disease among the transmissible spongiform encephalopathies, depicted here with a sponge. It's a neurodegenerative disease, making vacuoles in the brain tissue. It's visualized on the right in red, showing these prions. What is special is that this is prion diseases they are quite new, and it's important to understand that there is no the only infectious agent in these diseases. It's a misfolded cellular protein. So it's something that we have, which is physiological, which changes and induces disease. And it's special, of course, since it's in some of the strains, it's contagious and it's transferable in experiments, being only a protein as a source of infection. So the oldest known description of prion diseases are in sheep with scrapie. It's a couple of 200-300 years old descriptions of disease manifestations. We have in humans, kuru, which was from cannibalistic rituals transferred from people to people, eating central nervous system. We have chronic wasting Creutzfeldt-Jakob disease, which is the primary bulk of the human diseases, sporadic cases, 80% of them. We also have, as we will see today, chronic wasting disease in cervids. And further, we have in cattle, which was unfortunately also transferred to humans with variant Creutzfeldt-Jakob, which is cattle disease in humans. And the latest branch of this tree was published in 2018 with dromedary camels showing prion disease, which have characteristics quite similar to what has been in classical scrapie and also in chronic wasting disease concerning the spread of these prions into through the body in lymphatic tissues. So prior to the detection of this animal, which was in 2016, chronic wasting disease was something that we had surveilled since the early 2000s. But of course it was a huge shock that we discovered it in Norway. This was a disease of North America since 1967, the first detection and description. But it's actually the last 20 years plus minus which really has driven this infection in the North America, including now 26 states in the US and 3 provinces in Canada. So it has emerged in that continent. And also we like to think of it as a merged disease also in Europe with this case in reindeer. This was found in Nordfjella. It was the first case of prion disease in cervids in the European continent. It was the first to be detected in wildlife reindeer or wild ranging reindeer. And just to tell a little bit about the epidemiology of this infectious agent. Yeah, it has a long incubation period where the animals in these contagious strains are able to shed infectious material, the prions, through saliva, urine, and feces into their fellow animals and also into the environment. This long incubation can be for up to years. Going into a more clinical stage where the chronic wasting disease naming in the US early back is just a picture of how the animal appears in the terminal stage. It walks away and you have behavioral changes, you lose bodily control because the brain is affected and destroyed, and you will then eventually die. It's invariably fatal. There is no cure. We don't have any prophylactic tools, no vaccination possible today. And the carcass will then surplus infection to the environment, which is complicating this picture very much because the prions are very resilient and they will stay infectious for years in the environment. Makes it hard to manage. As it was said earlier, One Health has a component of the political issue. When chronic wasting disease was detected in Norway in this reindeer, in Nordfjella, which is Hemsedalsområdet, it was a scientific background. We used information from the US and the understanding of prion diseases both in animals and humans. We have had long experience with scrapie in sheep. So we used this information to give and guide the political society, which made a decision to take out all of this herd. It was 2,500 animals, more or less. The status today is the situation that we have discovered. Yeah, it's covering the whole. Sorry, but it's kind of feedback. Oh, yeah. This is the status. We have discovered sporadic cases like we have in humans, in cattle, and in sheep. We have discovered these sporadic cases in moose and red deer. 2 red deer only in Norway, some moose, both in Norway, Sweden, and Finland. and we discovered also this, as we characterize as a contagious form in the reindeer in Nordfjella, in the middle there. There's no pointer on this, but the big square is 19 animals that was taken out with this herd, and we unfortunately discovered one more case at Hardangervidda last autumn. So this is animal disease, and it's characterized as that, but we also have a precaution because of this history of variant Creutzfeldt-Jakob coming from the cattle. So we have a precautious attitude towards prions into the food chain. And though it's classified as a animal disease, the zoonotic potential is not completely ruled out. It's not to be excluded completely that this could not become a health issue for humans. But I think in this aspect, as a One Health conference, it's also a matter of, or one could discuss whether the mental health, not only the somatic disease in humans, but also the mental health of this managing these diseases, chronic wasting disease and a lot of other diseases, they cause a lot of intervention and make a lot of problems for the mental for humans. So it could be discussed. Since this is going directly, the management actions are going directly into the wild populations, which is, it's rather uncommon that we do that. We have had examples in salmon, of course, with Gyrodactylus and so on. But usually we don't intervene into the nature trying to control diseases in wildlife. But since this is animals that are in the cervids, and especially the wild reindeer, is a species that we have a responsibility for internationally, and also there is a old history. I mean, it's a thousands of years old history of hunting culture around these animals. So it's a lot of course, it's strong feelings, and it's difficult when we try to manage, and then we slaughter down populations, which normally should be there for interactions with human in a totally different manner. And of course, we have a huge population of semi-domesticated reindeer. It's about 750,000 animals across Sweden, Norway, and Finland, connected to the Sami culture. And this is all indigenous cultures that we hold very precious, and these are also violated by such a disease if it gets spreading into those populations. Also, its management provoke what kinds of difficulties towards farm animals, the land use, are they the overlapping habitat use for the cervids and the farm animals? Will they pose any risk of transmitting the disease, either because they contract disease or as mechanical vectors? So it's difficult, but it includes a lot of issues concerning land use. And also internationally, of course, chronic wasting disease is 1 minute, yes, I will do like this, and try to depict the center of this one animal, the reindeer, on what kind of, all the aspects that it concerns. It concerns the human health, zoonotic potential, maybe, the cervids, the hunting culture, thousands of years old. We have the Sami culture. We have the land use. We have the international. Norway is on the map in the center there, because we have an international responsibility not to transmit this disease to other nations and other populations. We also have the reindeer as it's an endangered species. We have the remains of the mountain caribou or the mountain reindeer in Europe with our responsibility. So it covers a lot of different aspects concerning the society. Thank you.
Yeah. I grew up on a small farm with the fear of scrapie in the western part of Norway, so I'm aware of the mental burden with the prion diseases. The fourth speaker for this session is Yogita Thakral. She is a doctoral researcher at the Department of Informatics at the University of Oslo. She's doing her research on antimicrobial resistance in India, and is a part of a bigger project on designing and developing a surveillance system. The title of Yogita's talk is Analyzing Determinants of Inequities in AMR Care and the role surveillance can play. Please.
Thank you for the introduction. I'm going to be addressing a different issue than we have been looking at today. I'm going to be talking about the determinants of inequity in AMR based on patients' perspective and the role that surveillance can play in it. So there are two guiding assumptions in the research before I start my presentation. First is social inequities. They do exist, and they impede the care and diagnosis, especially when it comes to resistant infections. And these inequities are visible in countries like India and other low-middle income countries. And that digital surveillance can play a role in making these inequities more visible and addressing these inequities at policy and practice level. So the research question that I'm exploring here is, what are the social determinants of inequity in AMR care, and how can they be best approached through digital surveillance systems? So the importance of equity in AMR is considered to be a lifestyle disease that affects different social groups in different ways. And these inequities, they constrain people from accessing and utilizing the healthcare and healthcare facilities that are available to them to live a healthy life that they value. And these inequities are magnified in a country like India with a huge social divide, which is my research area. So the dimensions of inequity in AMR in low middle income countries are surveillance, antimicrobials, diagnostics driven by these social stratifiers. My research focuses on antimicrobials linked with surveillance. Okay, so this research has been done in two northern states in India, Himachal Pradesh and Haryana. Himachal Pradesh is located in the Himalayan foothills and is a progressive state than Haryana and has better indicators than the other state in terms of literacy rate and other indicators, despite the fact that a huge fraction of rural population is residing in rural areas and seeking public health facilities. There are two streams of this research. First is the study of stakeholder practices to assess their prescription dispensing and consumption practices. The second talks about the design and implementation of an AMR surveillance system in a public teaching tertiary hospital in Himachal Pradesh. So I'll start with the first part of my study, which is the stakeholder practices. So for this study, I've interviewed around 60 stakeholders, including physicians both from private and public facilities, physicians working at pharmacy stores in the premises of hospitals and who have their stores outside the hospitals, MRs, medical representatives who are visiting the pharmacists and physicians, and patients waiting for their consultation in queues in the hospital, and people from the community. So what we have seen is medical representatives are driven by financial logic. They promote the brand names. Physicians tend to overprescribe or prescribe the antibiotics that are generally not necessary. There are very few orders for susceptibility tests because physicians feel they might lose their patients to other physicians. And they have no sources of updating their knowledge after they have passed out of the medical colleges. Pharmacists feel entitled to dispense antibiotics because they think they have the practice for years and they can dispense and informally prescribe antibiotics to patients who are coming without prescriptions. The sales records are not maintained. If they are maintained as a formality. Few records are maintained each day. And pharmacists have no source to update their knowledge as well after they've completed their pharmacy degrees or diplomas. Patients are self-medicating and diagnosing, and they are not aware about antimicrobial resistance or the use of antibiotics, and all of these practices are leading to inequitable use of antibiotics. So we have listed these inequities based on the practices in the community. So these inequities are based on the practices, inadequate knowledge and awareness that we have seen, weak regulation and implementation of the existing regulations, and poor reporting system, which is leading to poor or no evidence based at the levels of policy and practice to make decisions for better patient care. So I'm going to be focusing on the last part, which is poor reporting systems. So this is a study, the implementation of an AMR surveillance system done at a public teaching hospital in Himachal Pradesh. They started using an application in 2019. It is a very busy hospital where there is a huge outpatient load of around 7,000 incoming patients per week. But unfortunately, the digital infrastructure is only available at the microbiology lab. All the processes happening around it, for example, the sample collection, how the samples are arriving at the lab, or how the results are disseminated to the physician or to the patient are manual. There are no digital patient record systems, so the patient clinical data is not integrated with the antimicrobial resistance data. So for example, in this picture, you can see on the left there is a register. One is for urine culture and one is for blood culture. These are the manual registers maintained at the microbiology lab, where a lab technician enters the results of the susceptibility tests every day, and a data entry operator who comes for like 1 hour when he gets free from other duties at the hospital, and he enters this information into the surveillance system. On the right, you can see a requisition form which comes with each sample the lab receives. And this form does not have any information on diagnosis, clinical history of the patient, or antimicrobial therapy, in the absence of which the clinical data, prescription data, cannot be linked with the test data, susceptibility test data at the hospital. So based on the practices and the lack of surveillance, we have identified the inequities based on a patient's perspective. These are poor access to basic healthcare services, poor quality of treatment, which is driven by financial logics of pharmacists, clinicians, and the medical representatives. Both patients and physicians and pharmacists have poor access to knowledge and less sources to update their knowledge, and there is increased risk of resistance because of lack of surveillance and inadequate regulations at both state and facility level. I am going to conclude with the role of digital. By rapid community-based diagnostics that can share data with a AMR surveillance system that is implemented at tertiary hospital. Prescription audit is a practice that is already being followed by some hospitals in the area. So if the antibiotic part is digitized, you'll be able to get more information on the prescription, and if these can be extended to both public and private pharmacists. Health promotion in the community through co-created digital content and innovative apps like IVRS, etc. And maintaining of longitudinal digital record of the patient so that results are disseminated both to the patients and to the clinicians, and report is aggregated at a facility level and can be sent to the state for making decisions at policy level. And we are gradually making our way towards some of these things. Thank you.
Then we are ready to discuss the topics that have been presented here. I will ask the 4 speakers, Yogita, Jørn, Cecilia, and Zuzana, to take the floor here. We have covered zoonoses, prion diseases, and antimicrobial resistance, so there is a wide spectrum of things to cover here. Questions to the speakers? Should be a... Yep.
Yes, it's partly because of my personal interest as well, but I have a question for Jørn. And because you mentioned the mental consequences or relation with relation to CBD. But what about the societal consequences? Or with mental, do you mean mental like in being scared that your animals, for example, contract the disease? Or what sort of, can you elaborate a little bit on the mental consequences? And with the societal consequences, I think you have communities in Norway, in Rauland, etc., which is heavily dependent upon the wild caribou in Norway, the wild reindeer in Norway. So, and I know there is a lot of discussions going on in those communities about, you know, how to deal with this problem. Do you have a comment on that?
Yeah, I think it should cover everything that is not somatic. So it would be public health, mental health on personal level. So it's just to drag into that discussion an element that is not, because when we talk about zoonotics, it's usually somatic disease that we talk about. But I think these matters and the management actions that we do, they have so huge impact. So it's the complete picture, I think. So it includes everything that you would mention.
Carlos?
Thanks to all four speakers. A question perhaps to Cecilia or Zuzana, but on the EGP, we spent a lot of time mapping tools, developing, testing these systems and these new frameworks on how to do risk and how to predict and prevent. From what you've presented, and as Cohesive reaches its end, how far are we from now implementing? So what needs to be done to bring these tools into real life? On the animal side, on the human side, or in the environmental, preferably in all. But how far are we and what is missing? So that this doesn't end up just one more publication.
Yes, well, from my personal point of view, this project is on collaboration. Yes, from my personal point of view, the project was focused on collaboration, and the plan was to meet personally every 6 months, and this has been not done in the last 2 years. So, unfortunately, I would say more collaboration on implementing more. Luckily, we can already provide the results online, and this website is going to be supported by MedVetNet Association that can maintain these guidelines and develop them further. Partly, it's also by Matrix project going to be also taken over. So there is a certain level of sustainability of the project results and further implementation of the One Health Risk Analysis system.
Yeah, I was going to say the same thing, that there are many tools developed within Cohesive, but these guidelines we're too close. Okay. They are almost finished. They will be published online very soon. And then if there is a change agent in one of the One Health stakeholders that want to strengthen the system for a specific disease or a specific part of the system, they are there to use. So.
Thank you very much to all four of you. My question goes to the same two ladies, actually. Most initiatives or organizations that really gets traction needs to work with the grassroots and the community and the regular members of society, but you have mostly worked with the scientists. If you were to work, would you use the same kind of strategy if you were to mobilize the society and the public?
I guess for our workshop, I didn't mention that, but for example, for the institutes are part of the scientific community, but for the Food Safety Authority, when we had them in the workshop, for example, we also had the local offices represented, who are very much on the ground, working hands-on with zoonotic diseases. And and we had wanted to have like farmer organizations and more representation to the grassroots and the, I don't know, if there's science in the real world, so the real world. Did that answer your question?
If I may say, this project has been initiated as a further collaboration between the collaborators in the MedVetNet Association, which is association between the Veterinary and Public Health Institute. And as a practical, most of the projects are actually run by the veterinarian institutes, and it's mostly focused on the animal health, unfortunately, less on public health. And it has been criticized by EU that there was little academia involved and little pharmaceutical industry involved. And as you say, also the end users are very important stakeholders in getting implemented One Health. So there is a lot to be done. This project was under the call related to the sustainable land use and not under the health. Although there was a publication of the call this year for One Health emerging threats, infectious diseases, that was under the health. So I hope that in the future project, all stakeholders that are relevant stakeholders in One Health are going to be included.
Just to follow up on that, yesterday I heard Line Wold from the Public Health Institute talk about lessons learned from pandemics, and one of the points she was mentioning was that the sort of the lack of infrastructure you had for cross-sectorial or transdisciplinary collaboration, but what she emphasized was that sort of collaborating transdisciplinary between medicine and veterinary medicine sectors, that was kind of piece of a cake, because you share the same language, you know a lot about each other fields. But what she emphasized was the Public Health Institute needed to talk to school teachers and school authorities and totally different sectors, and that was difficult to manage. And did you reflect upon that in your? I understand you had a limited number of participants in your workshops because of the COVID restrictions, but did you reflect on how to collaborate with totally different sectors than sort of just the medical ones in your workshops?
Not in these workshops, as they focused on the signaling, risk assessment, and response and control, and then the school teachers, for example, are not that involved in that. They could be in the signaling if that's a way to find a signal that it's an outbreak or something. But no, we did not. We stayed within the stakeholders we identified, and schools were not on that list.
If I may add, we have another project called Mumir, and it's on the antimicrobacterial resistance with Salmonella, and where we had kind of division by the big victims are probably the youngest population and the oldest population, and also the communication towards them about the possible risks of infectious diseases and risks of use of the AMR is still, let's say, very relevant, and also the people who have a special diet. So I think, as you mentioned, it should start at school about what kind of diet, what kind of hygiene, the elements, the basic elements of public health should be taken into consideration at school or in the kindergarten. Yes.
Can I just add there? Now, when you said that, I remembered from the map that we did in our project group. We didn't have schools with, but we had, for example, care homes and hospitals and these type of institutions, but not schools specifically. But there was also other types of stakeholders in that system.
Can I go? Yeah. I guess it's for everybody in a sense, but in particular with relation to what Jørn has been talking about. Within public health, I guess, and we've seen that in COVID, communication between public health authorities and societies, communities, people is fundamental and of course prioritized and has been quite successful, I would say. Within the veterinary side, perhaps we are not thinking about that quite enough. You mentioned CVD and the impact that it's had on societies and people. We know a lot of other disease outbreaks we've been handling where we're handling the disease forgetting about people. That's an important aspect of One Health that possibly should be integrated. And I was wondering, how are you, do you have any idea how we should go ahead? How would you have approached this social sciences aspect of the CVD, handling of CVD? Huge question.
Yeah, and I don't know if I'm able to answer. I don't know if we are trained enough to that. But I think it's maybe a lesson learned. Like we have a lot of reports after pandemics and everything, because chronic wasting disease represents a disease on the border between wildlife and human health and livestock health, and also it bridges different, more than one governmental state, so to say. It's different ministries that has to work together and so on. So I don't know if I could answer your question very well, but I think it's very worthwhile to address it in the future. So and I can say that we have been talking a lot for 5 years, and I realize that a lot of what we have been saying maybe do not reach the target. And that's an implication of your addressing, that we should think maybe in new ways how to communicate when the questions are so complicated. And also it's new science, it's a lot of uncertainty, and the difficulties of handling on uncertainties. Definitely COVID has shown that and brought that more to the public. Then, of course, chronic wasting disease is a much smaller matter in scale, so at least for now. And but it's the same issues. So I think we should address it more. Yeah.
Okay, thank you for all presenters for presenting nice work. My question is directed to the one who present chronic wasting disease. So how do you see these chronic waste diseases in human being with respect to environmental enteric dysfunctions, or I think environmental entropy or environmental enteric dysfunction, which leads to the chronic wastes in a human being? So how do you relate these things with the cause? And the second is how your result is implemented and benefit the Norwegian people, and how your institution is linked with Institute of Public Health, Norwegian Institute of Public Health, so as to solve the problems that may have burden to the future. Thank you.
I think if we take the last question first, if I understand you right, how we interact and how we communicate the matter, it's partly like Hannah asked here now. It's we have tried to communicate, and of course we start with the things that we do the best and we know the best, and that might not be the communication. It's trying to handle the disease like we have tried to handle diseases before, and with emerging diseases and uncertainties and things that we don't know. I think we grab that first, and we have to handle because you have to action. And sometimes then you have to action without maybe having the proper time to establish a good communication, which is a challenge, of course. So I think it would be much the same answer as I gave to Hannah about that we have tried to communicate, but that's definitely something that we have to rethink and see how to manage to reach those stakeholders that need information. So, but and your first question, I'm not sure if it was the interaction with the environment, or could you please repeat the first? I'm not sure if I understood your first question. Okay. Thank you.
Thank you for all presenters. Maybe I have one question for the last presenter, Yogita. Yes, you clearly explained the role of antimicrobial determinants, especially from the prescriber side, dispenser and end user side. How do you consider the quality assurance mechanism, especially from the side of good manufacturing practices? Because it is one of the determinants for inequalities and the role of antimicrobial resistance, especially for country like India. There is a large industrial companies which produces different antibiotics for different regions. So the good manufacturing process is one of the determinants for this antimicrobial resistance. Thank you very much.
Yeah, India is one of the largest producers of antibiotics, but unfortunately that part is not a part of my manufacturing and supplying part is not included in my research right now. It starts with the prescription patterns and use of consumption of antibiotics particularly, and monitoring their consumption and surveillance.
I take the freedom to ask another question. And this is for you as well, Yogita, because when we discuss and approach One Health, we most often talk about cross-disciplinary approaches and multidisciplinarity and collaboration. That's very important. And so this has been discussed among veterinarians and medical doctors and ecologists and social anthropologists, etc. You represent informatics. That makes me a little bit curious. What are your thoughts on the role of informatics in One Health? Can you say a few words about that?
Yeah, sure. I mean, right now we are looking at the data which is being collected for surveillance of or use of antibiotics at patient level, which is certainly not available. But I'm sure if this data is available for, say, veterinary and environment domain as well, then and the data triangulation can help in making policies, and especially to treat patients as well as animals, and make some policies about the environmental domain as well.
To bridge the different entities, to bridge the environment and animal populations and human populations.
And to understand the connection better. So you have legacy data to understand the connection between the domains.
Thank you.
It's not lying manually.
Yeah. Thank you for the presenter. And my name is Yamrut from Ethiopia. My question is for the last presenter. When we say the issue of digitalizations on health is a big issue, and it needs skilled professions and the facilities, and as well the background or one's country income or other things are matters. And while you are saying the poverty and other issues, and maybe the pure political commitment, when we listen first the speech of the retired Prime Minister of Norway, the issue of having a food is a basic. Is there any commitment in India or in that place about One Health or digitalization towards to One Health? Did you have a communication with the policymaker and with the political decision makers?
In India right now they have a national action plan, and the AMR surveillance and AMR initiatives are limited with a research organization that have around 28 to 30 hospitals, public hospitals and private hospitals in their panel, and they get their data. They send their data to this research institute, which is then sent to global institutes like WHO and GLAS. But in general, there are treatment guidelines for infectious diseases that are only developed for human domain, not for veterinary domain. But most of the physicians during my interviews, I realized when I spoke to them, they do not know about treatment guidelines if they exist at all. So there are regulations, but they are poorly implemented.
One last question over there, and I see Jeanette is quite impatient, so.
Okay. Thank you very much for nice and really mind-boggling discussions, particularly. I'm too much inspired with the chronic wasting diseases. By the way, just this is not really a question, but it's a recommendation. So do you have a mechanism to conduct a longitudinal types of research just to follow? Because after just hearing here, I'm just Googling and I found a CDC report, mainly which is focusing on it can have the chance to transmit to human through eating of infected deers and elk. So it was reported by the survey in 2006 to 2007. And there is also a report here in Norway, as you have said it already. So through longitudinal exposures and through time, there is a chance to transmission. There is a potential chance to transmissions to a human being. And we don't know, it would be future pandemic, we don't know. So at this time, do you have any mechanisms or any research project that you are actually conducting on this particular area? Because we don't know the future. Thank you.
We do certainly have a long-standing surveillance program, and we also have research programs where we do experiments in animals, of course, which are models, and the best models that we have to investigate the zoonotic potential, but also the potential for spreading in other cervids. But all these are in mice models, different species of mice, and also transgenic mice, expressing prion protein from the actual host species that you are interested in studying. So we do that also in humanized mice, as we call them. They are transgenic mice producing human protein, prime protein, which is a needed source for being converted. So we do have experiments, but it's hard when of course you can't do experiments in humans with this. So we are trying at the best to investigate the zoonotic potential, and also the development in cervids. We have wanted to make experiments with inoculating cervid species with these contagious strains, but we have not been able to do that. But it's something that we very much would like to do.
Thank you. Then we have to end this session. So thanks to all you for the engaged audience, for all the questions. You have really shown that zoonosis, One Health, that's not only medicine and natural sciences. It's much more than that. So thank you.
Thank you very much to the speakers and the moderator of the session. We are now in the postprandial phase, after lunch phase. So ladies and gentlemen, up and stand once more. We are approaching the last session. Second to last session, stretch. Come on, the benches are not better than they were this morning, so I know that you need to stretch. Thank you very much. Please sit down. I have the privilege of presenting the next keynote speaker, as well as the moderator of the session called One Health Environment and Biodiversity Loss. Dag Hessen is a professor in bioscience at the University of Oslo, and he heads the Center for Biogeochemistry in the Anthropocene. He works on the link between climate, carbon cycle, and ecosystem processes, and is also an author of several popular science books. So please join me welcoming Professor Dag Hessen. Thank you.
Yeah, thanks a lot. Well, I'm a biologist. My father was a veterinary, and I almost started studying medicine, so I've had a bit of each of the disciplines here. But I'm also, besides being a professor in biosciences, working with everything from genes to ecosystems, I'm also head of this center with an extremely complicated name, so we can call it CBA for short. But this is also cross-disciplinary within the natural sciences. So we are atmospheric modelers. Actually, 2 key authors of the last IPCC report is affiliated with our center, and we have chemists, geologists that work with permafrost thaw and things like that, and of course biologists working with understanding how this affects ecosystems and how carbon is taken up. Because by and large, this is to understand the extremely complex carbon cycle and how it's embedded with the climate and nature loss, which I will soon talk more about. So of course we all know that there are planetary boundaries. This is the iconic graph from the Stockholm Resilience Center, and we all know that there are also boundaries that by far are exceeded, and there are boundaries that we approach. Of course this is the kind of reality that we have to face, and that should frame all human activity. And interestingly, in the Norwegian new governmental platform, it's explicitly stated in the beginning that from now on, climate and nature should frame all politics. I mean, it remains to be seen, but still stating that, I think, is a big step forward. And both to realize that this is about climate and nature. And of course, earlier today I had a lecture where I also expressed how tightly embedded this is with health, inequality, and in fact not all, but a fair number of the sustainability goals. So I'll just start with this overarching picture, because before we dig into the direct links between ecosystem health and human health. So the Anthropocene is probably a well-known name to many of you, and it's about to become official. Yeah, I missed it here, but by and large, it's of course characterized by the fact that CO2 and other greenhouse gases like methane and nitrous oxide have increased to an alarming level. And that we have a remaining capacity up to the 1.5 or eventually the 2-degree target, or actually upper limit, I should rather say, which is a really big number. But the point is, with the current emissions, we hit the 1.5 target within less than 10 years, and the 2-degree target in a couple of more decades. So, I mean, this is really a rushy business. And again, this reality should, of course, frame politics, just as it's stated in the platform I mentioned. And we also know that there is a tremendous loss, not only in species, but also in nature at large. And of course, the loss in nature implies loss of species populations, the population size of species, which this first number referred to, that we have a global average decline in invertebrate populations of 60% approximately within 4 decades, which is not the same as extinction, but it says something about the tremendous human footprint on the planet. And also we have this, it's probably not right to call it a fun fact, but at least it's a fact easy to remember, that if you look at the biomass distribution between on terrestrial vertebrates, we see that one single species, namely Homo sapiens, make up 36%, our domestic animals 60%, and what remains to wild animals, vertebrates then from mouse to elephant, is no more than 4%. So again, this shows the tremendous toll we are taking on the planet surface. And we have degraded wetlands, forest, land surface, coastal system, etc. dramatically. And we also have this and much more sums up to this Earth Overshoot Day, or actually it should be called Earth Undershoot Day, the day where we have exceeded the annual production capacity of the planet, both in terms of renewable and unrenewable resources, and also when it comes to waste like CO2 and other waste. And of course, this is not an accurate calculation, But it's an estimate, and these days come earlier each year, and this year it came the 29th of July. And of course, there is a strong variability within nations, so this can be broken down also at the national level. And if everybody had the same shoe size as we have in Norway when it comes to ecological footprint, that overshoot day or undershoot day would appear in the mid of April. So that's of course also an issue in this context. But I think this is very important, and finally this is taken also politically. And we see this now also in the Glasgow negotiations, that nature becomes part of this, because we realize that these things are intimately related. So, right, the last sixth IPCC report, the first technical report, the other is still in the pipeline, that we all recognized, stated pretty much what we knew from before, but with the bigger letters and more serious numbers and with better models. And also it put forward some better estimates on future climate change, and also made it very likely that most of the extreme weather we are seeing is linked with climate change. So, I mean, this is just a few numbers, but they are, I would say, pretty serious. Along with this comes then the IPBS and other reports, but especially the sister organization of IPCC, the IPBS, that gives good updates and numbers of the diminishing nature and also the species loss and the declining population species. So, and these things are tightly linked together, basically expressed here. And I will spend a few minutes just on this because it expresses exactly why there is such an intimate link between nature and climate. And of course, all of you that read the Lancet Countdown report and other reports of this are familiar with the fact that climate is by far the most important threat to human health in various ways, directly and indirectly. So of course, everything that adds to the climate change or detract to the climate change has of course huge indirect implications in that sense. So the point here is that if you look at the red numbers, and this is pretty much the processes we are studying in the center I'm heading. If you look at the red processes, red numbers, that's the human emissions. So it's around 9 to 10 gigatons per year. But less than half of this remains in the atmosphere. It's still sufficient to give this alarming rise in CO2. But if ecosystems per se, primarily by photosynthesis and some geological binding, takes up more than half of this, we would really be in serious trouble. Well, we are in serious trouble, but even worse. So this is the reason why forests are important. I mean, if the Amazon forest reaches a tipping point, which some people suggest might happen around 1.5 degree or somewhere between 1.5 and 2, where the internal hydrological cycle is broken, then of course all the carbon in the forest soon will reach the atmosphere, and also of course with a tremendous impact on the biodiversity and the indigenous people living there. So that's a kind of really risky tipping point. And also we see forest fires, increased incidence worldwide, even in the boreal forest at our latitudes there is an increased incidence, which of course transmits vast amounts of carbon from forest to the atmosphere. And with the permafrost thaw, of course, there are huge amounts of carbon stored, frozen in the permafrost. When this starts to thaw, as we see today, this will be released to the atmosphere, in the worst case also together with methane, which is an even worse greenhouse gas. It will, of course, accelerate the global warming, more permafrost will melt, and we see this as a kind of vicious cycle that we want to avoid. And that's partly the reason why we should definitely not exceed 2 degrees. And also the same with marine systems. When the ocean becomes warmer and more acidic, more CO2 will be remaining in the atmosphere. There will be less productivity in the marine systems and less carbon uptake, carbon sequestration. So that's, in a nutshell, why it's so tremendously important to keep healthy ecosystems. Yeah, it's also worth reminding that Earth is a really special planet in the big and cold and dark universe, and it's special thanks to biology. I mean, it started off like the dead sister planets Mars and Venus, but thanks to biology, we have ended up where we are now, which is just perfect for life. 400 ppm CO2, actually it should better be 200, but anyway, and 21% oxygen. So the fact that Earth is thermodynamically unstable is thanks to life. So life is not only sustaining the kind of climate via a number of feedback mechanisms, it also is the basis for the type of climate we have today. So I mean, again, it points to the essential role of biological processes, and probably first and foremost the balance between photosynthesis and respiration. Of course, one consumes CO2, the other releases CO2, and vice versa for oxygen. So there are lots of things to discuss when it comes to climate. This is definitely undisputable that CO2 is rising. The greenhouse impact itself is also based on physical first principles, so that's also nothing to discuss. And we have known this now for decades. It's been warning since the early 60s that this was an alarming trend, and the warnings have become steadily more serious. And this is clearly a global phenomenon, of course. CO2 is distributed almost equally, and this is a picture I took myself 2 years ago when we had fieldwork in the high Arctic at Svalbard. It was the first time I really experienced a permafrost melting point where the ice had collapsed and given this pond beneath, which is something we now see happen more and more frequently. And in the mountain behind is the northernmost monitoring station for greenhouse gases, and that was the first station that recorded 400 ppm. So I think this is a kind of symbolic picture. So the question is, of course, how bad will it be and how will it impact biodiversity? The problem is that we really don't know because the scenarios span such a large stretch, but now we are heading somewhere between 2.2 and 2.7, partly depending on how the biosphere will react, as we've seen, but also, of course, it relates to how new technology, human behavior, consumption patterns, etc. will affect. So the question is, of course, then, why should we conserve biological diversity? Well, the basic argument is, of course, that there is this intrinsic value of nature rooted in what you could call deep ecology and ethics, and this is also the basics for the law regulating biodiversity. Then we have this very important for the human mind, the experience of nature and the well-being in nature, etc., the recreational value, which partly is biocentric and partly anthropocentric. And then we have these ecosystem services that, by and large, nature is the foundation for all sorts of life, and also, of course, very important for economic activity, which is sometimes an argument we need to use. So, of course, when the bees started to disappear, people realized that they were not only swimming about and buzzing around and producing honey, they were really critical for the pollination. And just to show some examples, well, we might not necessarily be dependent on coffee, perhaps except for Monday mornings, but it's, of course, easy to transfer this not only to food production, but also to monetary value, which is of tremendous importance for certain nations and local communities. And this microscopic fungi, just to recall that, of course, nature also provides all sorts of medicines, and bioprospecting is a very important activity. And this is the fungus that somehow changed the transplantation activity forever, because it dampens the immune system and means that you can transplant an organ from one person to another with minimum risk of loss. And of course, the company that discovered this, unfortunately for us, it was a Swiss company. They are now purchasing this for millions of dollars every year. So again, just a reminder of the importance of nature. And there is lots of important documentation, both books and a whole plethora of papers demonstrating this by hard facts and studies, notably related to pre- and post-operation patients, how nature and the seeing green stuff has this tremendous effect on physical well-being, stress, blood pressure, etc. And also the feeling of meaning. So this has a huge, but not really fully evaluated and appreciated mental health aspect. So we can say that, this is just some examples, but we can say that nature is a kind of free recipe for a better life. It doesn't cure everything, of course, but as long as it's there, it has this tremendous impact on the health. So again, I think the take-home from this is that we need to understand and appreciate the real values of nature. Nature is not a kind of free service that can be lost without costs. It should not be discounted either. We have this ability and tendency, especially in economic theory, to discount the future, especially when it comes to nature. And this is, of course, a completely wrong way of doing it. And also economically, nature should not be treated as an externality. Yeah, finally, of course, as we all are aware of, the nature loss have some consequences also on the increasing prevalence of various zoonoses, of course, especially now expressed by the COVID-19 pandemics, but there are a large number of studies showing that there is an increasing incidence of zoonoses because we enter into forest and reefs where there are reservoirs of these viruses. It's basically viruses, but also because we have this consumption of bus meat. So there is, I think there is a new awareness of this finally, but we are lagging behind. But again, I think it is rewarding to see this Norwegian platform and the new awareness also in the EU system and the Green Deal, etc. So again, who should act? What could be done about this? And I think this is a kind of circle that starts with politics. It needs to engage the society at large. If not, this is a lost case. And it, of course, also needs to impact the producers. And of course, there is a huge interest now in the financing market to really play along with this. And of course, we also need science on this. We can. Time is running out, so we can ask if there is a COVID-19 tipping point. Many people have asked this, and I would say yes until recently. But now we see that there are signs that the world economy is fired up again with coal-fired plants, etc., due to things like the gas prices and shortage of energy, etc. So, but of course, the point is that we should take the lessons from COVID-19 to help bring the planet tipping in the right direction to the right. And again, I just end by this, which I think is always inspiring to think about. This was a wallpaper I saw in Bergen, so I took a photo of it. The greatest threat to the planet is the belief that someone else would save it, and I think that's something that we should keep in mind, just both as individual, as member of the society or the working place or whatever, and also as a nation. I mean, we also often have this tendency to think that the world should be rescued by somebody else, but we all have a responsibility. So that was the keynote. Thank you. Then I take on another hat as moderator. The next speaker here is Carsten Schwermer, who will speak about the expected efficiency of interventions at the Norwegian wastewater treatment plant to minimize AMR emissions to the downstream environment. Carsten is working at NIVA as a research scientist, Norwegian Institute of Water Research, and he works with water quality and treatment, and his current focus is on applied research and developments related to technical interventions against AMR. So please, Carsten.
Thank you very much, Dag, for the nice introduction, although it's a very long and complicated title, but the message is, I think it's easy. I want to front the AMR and monitoring the environment and interventions. So we are looking for solutions of the problem already now. My talk is then about the expected effectivity of solutions installed at wastewater treatment plants to minimize AMR emissions to the environment. And we look at a case which we have done a couple of years ago at the Norwegian wastewater treatment plant that discharges to the local river. Which button do I have to press? Here's the green one. Yes?
It's a bit hard.
Yeah, right. Okay. Yes, so you're probably familiar with this situation where we are all in sometimes, being on the toilet. But actually, did you know that given when you're medicated with drugs and you're getting antibiotics, that your feces and urine contains both drivers and carriers of AMR that then are released to the environment? We have seen this poo today already. But independent if you stay in the hospital or at home, and that is my take-home message, actually, because you are already influencing this at home. Now, you think this is taken care of somewhere else, right? Wastewater treatment plants are important receptors and point sources of AMR. That was shown. However, today's plants are not designed to remove these contaminants, and there are no official restrictions or limits on that. In fact, it was shown that wastewater treatment plants do not retain or remove many, or if not most, carriers and drivers of AMR. This means that these contaminants are released into the downstream environment, such as rivers, lakes, and the fjord. The resistance genes can interact with harmless environmental microorganisms. And through a feedback reaction, AMR then returns into the society and into our health institutions, where it causes problem of defensiveness against the common diseases. And therefore, the environment plays a major role regarding AMR spread and dissemination and its feedback into the society. So the question is, how can we stop the flow of AMR pollution into the environment? And there are, of course, several options for interventions. And those include precaution at sources, such as hospitals, but also at home, with reduced consumption of, for example, antibiotics. But there are also technical measures at sources, hotspots, and dissemination points. And one of them being wastewater treatment plants, because they are collecting the pollutant streams from different sources, and there are where the flows merge, and so the handling of this problem can be done there. The challenge, however, is that AMR is actually not a traditional contaminant, but it's genetic information in case of genes which can be picked up and thrive within this environment. So the traditional wastewater treatment plants are not designed to remove it, and the removal is challenging. And therefore, advanced technologies are needed in order to remove that problem. And further on, I will show some results of the study we have done a couple of years ago. We were looking at the question, how much antimicrobial resistant genes do today's wastewater treatment plants emit? So what is the current situation? And we measured the concentration of genetic markers that code for important resistances in the effluent of 3 major Norwegian wastewater treatment plants. And those were discharging to the fjord and to a river. And what we roughly see from this complex diagram, that there are no large differences between the plants with respect to the most abundant gene markers which we have detected. And the ARG levels within what we have measured are roughly 10 to 1,000 times lower than measured in many other European wastewater treatment plants. So this data set was a part of a screening study in Europe. So then the next question was, what is the contribution of one of these wastewater treatment plants to the downstream environment. And we have taken a case of a wastewater treatment plant discharging to a river. And we have determined mass balances by measuring flow rates and ARG concentrations upstream the river and downstream the river and at the discharge point of the wastewater treatment plant. With regard to the volumetric flow, so the volume of water that enters the river, we looked at the relationship between the flow rate in the river and the proportion of the wastewater treatment plant to the total flow. As expected, at minimum tide, 45% of the contribution by the wastewater treatment effluent, so there was a high or significant contribution of the wastewater treatment plant at the minimum tide. And this represents the worst case scenario, because when the river is dry, and in other countries the rivers are often dry, then the wastewater treatment plant volume is high. And while during a flood or high tide, the effluent is diluted. However, although diluted, genes will not be removed from the water and still enter the environment. Then we have looked at the ARG concentrations. And this diagram shows the concentrations of ARGs measured in the river upstream and downstream and at the wastewater treatment plant discharge point. We see that there is no differences between the sampling points, and that was surprising. And that means that the plant is not contributing to the ARG levels more than the background in the river. An explanation could be three hypotheses. The first one is that the river was sometimes going in the opposite direction, so you have a mixing of the water column, and the contaminants are always there. A second explanation is that the river upstream contributed to the pollution, and it's known that it's full of intestinal bacteria. And another one is the contribution on contamination from the runoff water from surfaces, including from agriculture and animal feces. Then we ask, I don't see the picture, what is the expected effect of improved treatment, any improved treatment installed at the wastewater treatment plant, either by optimizing the treatment or by installing advanced treatment. So this is what we are now modeling before we install anything. And this is very important to know for any policymakers and plant owners. And we have then looked at the contribution of ARGs from the wastewater treatment plant to the river. And here we considered 1 log reduction, just to model, and a yearly average tide in the river. So the normal flow rate in the river. And as you see, currently, as shown by the white columns, the contribution of ARGs from the wastewater treatment plant makes 11% on average of the 6 most abundant genes. An assumed improvement by 1 log or more would reduce this contribution of the wastewater treatment plants to below 2%. So that was a significant improvement by the plant. And then we modeled the worst case scenario when the river was dry. At a low tide, the contribution of the ARGs from the wastewater treatment plant effluent makes 40% on average of the 6 most abundant genes. An assumed treatment or improvement of the treatment of 1 log or more would reduce this percentage to below 10%. I have 3 take-home messages, and that is that we need to reduce AMR pollution, and I think we all agree with that. But both at sources and end of pipe, such as wastewater treatment plants. The environment, as defined by One Health, starts in your toilet. Because wastewater treatment plants are our future resource factories. They are not waste dumps. And they need to protect it from any harmful contaminants and organisms. The second thing is that we need to generate more knowledge on intervention methods in order to guide policymakers and plant owners during decision making. And they need to have this for cost effectiveness evaluations. And then we need to have this surveillance system of AMR in the environment in order to understand what AMR is and how it spreads, and in order to estimate risks. And with this, I want to thank my co-author, Wolfgang Uhl, who disappeared again, for contributing to the study. And our work was stimulated by a cost action program, NIREOS, and was internally financed by NIVA. Thank you very much.
Thank you, Carsten. So we stay with the water and we stay with NIVA, and the next presentation is by Pavel Kresminski, who is an environmental engineer and works with advanced methods for wastewater treatment. So please, Pavel.
Thank you very much for the introduction. I'd like to talk a bit about an upcoming project, or the project that we just recently started, and it's called Pairwise, and it's about dispersal of antibiotic resistance and antibiotics in water ecosystems, and also the influence on livestock and aquatic wildlife. So the project is funded through the national and EU funding through the Aquatic Pollutants Call, which is co-organized by JPI Water, JPI Oceans, and Water JPI, and it was funded under the team measuring. So basically mostly focus on monitoring. It's a 3-year project that started just in the middle of September, and the budget is 1.5 million euro. So we have a collaboration in the project of a research institute and universities coming from different sectors, including environment, agriculture, veterinary, and wildlife. The coordinator is Swedish National Veterinary Institute, and we have partners from Sweden, Spain, Norway, and also from Tunisia and Uganda. So I've took the liberty of copying the picture from the recent VKM report on AMR in the environment, because it very nicely will fit into the topics that I will discuss. So basically, the background for the project was actually what Carsten presented a bit. It's that wastewater treatment plants are point sources for both antibiotics, but also antibiotic resistance bacteria and antibiotic resistance genes. And they are sources of those contaminants spread into environment and wildlife. So, but still, even though we know that they are important point sources, there are still limited knowledge on how these contaminants disperse in recipient aquatic environments, how the antibiotic resistance bacteria, genes, and antibiotics itself, occurrence and levels are affected by environmental factors, and how they influence antimicrobial resistance occurrence in wildlife, livestock, and also humans. And on top of that, it's still a bit unclear how wastewater treatment plant effluents really influence antibiotic resistant bacteria and genes carriage in livestock and wildlife. So basically what happened is that in this picture, I've tried to copy where our project, the new project, will try to look into and improve knowledge about AMR. So that it includes both freshwater, marine water, cattle, birds, and wastewater treatment plant effluents as well. So the objectives of the project are to improve understanding of dispersal of antibiotic resistant bacteria, genes, and antibiotics in water bodies downstream of wastewater treatment plants. And we will look into different geographic areas, different climatic conditions, and different types of water. We will also try to improve the knowledge about the spreading of antibiotic resistant bacteria and genes in livestock, upstream and downstream environment of the wastewater treatment plants. And last but not least, we will look at the role of wildlife, and for that one we will use wild birds and how they contribute to the dispersal of antimicrobial resistance. So the project is kind of divided, let's say, in 4 work packages, and they are one is a coordination, and the other 3 are focusing one on water, one on livestock, and one on birds. So we're going to have 10 study areas within the 5 countries, and in Norway that will be a local area around Lillestrøm, and we also have planning to do a sampling campaign in Svalbard. We're going to sample water, both upstream and downstream of wastewater treatment plants. We're going to also collect feces from wild birds, and we're also going to collect samples from livestock grazing on grasslands nearby the wastewater treatment plants. And based on those sampling campaigns, we're going to analyze antibiotic resistance bacteria, genes, and antibiotics itself. So we will have basically a case study in every country that participates in the project. And the approach that we have regarding the methods is going to be a combination of phenotypic and molecular methods, and we're going to combine it with telemetry data on animal movements. So for the birds migration, we're going to use combination of GPS tracking and non-invasive sampling of ARB and ARGs carried by gulls. So we're going to track them from Uganda to Tunisia, probably through Spain and also up to Svalbard, obviously if we are lucky. So that was a very short presentation since we don't have the results yet. So I hope for the next One Health conference we have some concrete data to show. And I'd like to acknowledge the funding, of course, which comes from for NIVA. It comes from a Norwegian Research Council, and also for the other partners that comes from national funding on top of the EU contribution. Thank you very much.
Thank you, Pavel. Excellent. Then we are almost back on schedule. So the next speaker is, then we move from the water to land. And the next speaker is Mette Goul Thomsen at the NIPH, is that right? Yeah. And she will speak about biofarming for bioactive compounds, preliminary results from screening and in vitro investigation of herb extracts. So please, Mette.
Thank you very much. Thank you for the introduction. Thank you. Yes. Thank you for the invitation. It was actually my colleague Rune Slimestad who was supposed to be here, so I had to step in. Yeah, you have already been introduced to this project earlier today, so I'll just shortly touch into the background for the project. The background has been an increasing concern into the use of antibiotics and synthetic antioxidants in the food and feed industry. And there has been a steady increase in the interest into looking for alternatives for these synthetic compounds. And we know that a number of plants have been both previously and are still used into the herbal medicine and also for processing the compounds that are interested here. So the main objective from the Bioactive project has then been to, firstly, also to, importantly, to increase the value in the Norwegian plant production. We know that there's interest into using both wild plants and cultivated plants grown in Norway due to both that we have a rich flora, but also because we have a clean environment. So what we are doing here is then looking into compounds produced from herbs possessing antioxidant, antimicrobial, and anti-inflammatory activities. And the compounds will be tested out in fish and poultry feed and also in packaging materials to improve fish or to improve the shelf life of the packed produce. The plants have been selected based on both a knowledge into the use of these plants in traditional and folk medicine, and also that the knowledge that we know that these plants are either present in the Norwegian wild nature or that we are able to produce them here. So we see here that the 9 different species of plants that are included in this project. And we also know that within the species there is a large variation between the different varieties. So we have therefore also included different lines of the species. Here it is, yes. I'm just going to jump back and forwards here, sorry. So we see that, for example, we have germplasm collections at NIPH from a number of these species. And we see from previous studies there's a large variation into the content of the bioactive compounds in these plants. So for example, we see here from the results from the content of essential oils in the yarrow collection. And we see here 9 clones, and there's quite a large variation in the content of essential oils. Yarrow is actually known as an old malaria plant, and in the First World War, then the soldiers had yarrow in their medical bags, using for treating their wounds. So it has a long history into the use. And we also have a large collection of the plant roseroot, and we see here the marker compounds and the large variation between the lines in this germplasm collection. There are also a number of other factors affecting the content in the plants, not least the post-harvest processing of the plants that we have to be aware of. And another aspect is that we also found in previous studies that even though we have marker compounds that we recognize the activity in the specific plants from, then this may not correlate to the biological activity that we find through studies. So we therefore also have to be aware of this when we select plants, that they contain both a combination of the compounds and compounds that we may not yet have analyzed for. And a number of the plants that we selected are already used into implementations like we are in this study. For example, the hops, where we, of course, you mostly know this for the beer production. And in this connection here, it's the alpha and beta acids that are the active compounds. They are also contributing to the bitterness of the beer. From these plants, we have made different extracts, and there are 3 different kinds of extracts made. One extract is made from the solvent dichloromethane, the next one is from ethanol, and then the third extraction with water extracts. And then we have tested these extracts for the antioxidant activity. And we here see the slide here shows the activity of the dichloromethane extracts. And we here see that the activity of hops and rosemary is the highest. And then we get artemisia and the roseroot following those 2. If we look at the other extracts, then we here see the ethanol extract. Here again, the hops gives quite a high activity in the ethanol extract. But we see there's a number of other plants that then follows here, roseroot, yarrow, and artemisia. If we look at the water extract, here the oreganum is the one with the highest activity, and then we have the hops and the roseroot. Overall, then we had the highest activity from the water extracts. Following this, then there's now starting up a preliminary test at Nofima, where they're testing. So far, they have tested some of the plants in the dichloromethane solvent, and we here see the antimicrobial activity in the test in the plants. The chart here shows those plants that were selected based on a high or high plus activity. And we see that for the high activity, we have the yarrow, Atilia millifolum, and we have Artemisia, hops, and rosemary. When it comes to the highest activity, that was found for the hops. And this is the cones of the hops that is used. So these are all preliminary results as the project has just started up. And we will continue to 2023. And I want to thank you for your attention and also thank my project partners. Thank you.
Thanks a lot, Mette. Then the presenters, I assume, could take the podium here. I think there's a free seating. But since I'm also a moderator, I think I will keep my position here to monitor everything. But of course, if there are questions or comments to my presentation, feel free to raise those as well.
Ann-Katrin Arena, Norwegian University of Life Sciences. Thank you for your presentations. I have many questions, but I have one question for Mette. I was wondering if there's any knowledge about the mechanism of action of the antimicrobial effect you see of these compounds that you extract from plants, and if there is any risk of cross resistance if you would add these to feeds routinely.
I'm not quite sure if I understand because the cross-contamination, what do you mean?
Cross-resistance.
Cross-resistance?
Yeah.
Thank you. I really don't know if I don't think I can answer your question. I haven't got that knowledge.
Okay, thanks.
So it's quite easy.
Others?
Picking up on the effluents and on the water treatments, on top of these strategies, I mean, we're a very privileged situation, perhaps, as you mentioned, that we don't have as much use of antimicrobials in the country. There might be less resistance in water systems. But on top of water management plans, what other solutions from the management side would you, I mean, now I'm asking perhaps Niva, not just you, but what other solutions would you feel comfortable in suggesting for reducing the burden of antimicrobial resistance in environmental ecosystems?
I would say we should start at the source, and that is precaution. Prescriptions of drugs starts at the hospital and the doctors. Most of that is going actually into your home, and there where it starts, and that's the human sector. Then the animal sector. Norway is quite, I think, flinke, quite good in handling antibiotics, because in other countries it's a large consumption, and that has to change. And then when we come into the end of pipe solutions, there are, like in other countries, perhaps also the industry where the drugs are produced. So the industry has to give their contribution as well, and we have to also know that there are also other drivers of AMR that may be heavy metals. So it's a cocktail of and the pressure, the selective pressure that is on the organisms So it's not only at treatment at wastewater treatment plants, but it is more, and that needs to be found out, because we have to screen in order to find out where are the sources.
We joined a project with NIVA also on pharmaceuticals in wastewater and in natural ecosystem, and it was a surprisingly high level of pharmaceuticals that even reached level where they had impacts on the biotic communities. So our other, yeah, Christian.
Thank you for your presentations. And one thing is the actually doing something about the problem and to remove the genes and potentially the resistant bacteria from the effluent from the treatment plants. But I just want to, it's more like a comment, because I think it's very important to look into the role it can have in AMR surveillance as well in the community. So not only to do something about the problem, but actually to use sewage and the effluents from treatment plants to get a better overview of the situation regionally and nationally. And I know that's very important in many countries with a poor functioning AMR surveillance system as of today.
Yeah, well, I agree with that, and it's a thesis where it's related to AMR is related to feces, and that is where it hits the pipeline, and there is where the environment starts, and there is where we can monitor that. And it's important to monitor to find out what is the situation, where are the streams, the important streams, and then based on that, what can we do? In other countries, they have already started with interventions at hospitals, at wastewater treatment plants. In Norway, we are not going to do that, happily, and yeah, but it's not the only solution. And that was also pointed out in the Kunnskapsrapporten, where the health sector has given their comments on that. It's not only the waste streams we are looking at, it's more complex. And that was shown today, how complex and broad this picture is.
We are waiting for the next. Was there one? Yeah, that is, of course, when it reaches the treatment plants, that's one thing. But it's quite an amount of runoff that is diffuse and exceeds or doesn't really enter the treatment plants.
That's true, and that is what projects should find out. I think this pairwise project probably is looking at. They are looking at birds and.
Yeah, I mean, basically, of course, wastewater treatment plants and what's getting there is only part of the picture, right? It's probably a bit easier part of the picture to look at because we know what's getting there, more or less, while the diffuse sources are obviously diffuse, so they are more difficult to track, but they should not be forgotten. But when we talk about an intervention, of course, you should also, if you have a low-hanging fruit, you should also try to address it. So I think trying to fix things at the source is obviously a first priority, but then if you cannot fix it at the source, then you should look at the end-of-pipe solution. And obviously, in that, there should be also diffuse sources mitigation.
Right, thank you. Then there was...
Yeah, it's here. Okay.
Please.
So I have a comment, not a question, to the moderator, professor, Center for Biogeochemistry. So that the name was really interesting, the center name. You showed us, or you blurred the link, particularly just focusing only on addressing infectious disease threats on both humans and animals. And you showed us the interconnectedness between the change in climate and land use, mainly, just because you focused on issues related with health and the biodiversity. That was interesting. So further, I'm wondering that what if we consider population dynamics, foreign policy, issues related with biosecurity, just to think about One Health, I thought that we need also broaden our thinking to this also. And even we can complicate the namings.
Mm.
That's it.
Yeah, the things I touched upon, I think, was, if I got it right, that's just a tiny part of the whole complicated issue. And I mean, all the 17 SDGs are more or less tied together. It has to do with the distribution of wealth and of course, the spreading of infectious diseases, which again has to do with land use, and land use has again to do with poverty and climate, etc. So I think there is, and that was why I stressed that land use or nature loss has this tremendous feedback on climate, because climate again has all this suite of impact on health-related issues, both directly in terms of avalanches, floods, loss of drinking water, crop failure, pest outbreaks, as well as more subtle effects like, or direct effect like heat shock, and also, of course, spread of infectious diseases, etc. So I think, I'm not sure if I got you completely right, but that's really a huge and complicated issue. But I think at the base of this lies then the interconnection between nature degradation, climate, and health issues. I was reminded that we are, well, it's exactly on time, isn't it now? So, so then there is time for a very important part of the program, namely a break. So thank you all.